Infant botulism and honey risk. Infant botulism is a rare but serious illness that affects approximately 100 infants in the United States each year, with a mortality rate of less than 1%. The pathophysiological mechanism involves the ingestion of spores of Clostridium botulinum, which produce a toxin that blocks the release of acetylcholine, a neurotransmitter essential for muscle contraction. The key diagnostic approach involves a combination of clinical evaluation, laboratory tests, and electromyography. The primary management strategy includes the administration of BabyBIG, a botulinum immunoglobulin, which has been shown to reduce the duration of hospitalization by 3.5 weeks and the need for mechanical ventilation by 75%. Key points. Note: infant botulism affects approximately 100 infants in the United States each year, with a peak incidence at 2 to 4 months of age. The mortality rate for infant botulism is less than 1%, with a case fatality rate of 0.5%. Honey is a potential source of Clostridium botulinum spores, with 15% of honey samples testing positive for the spores. The dose of BabyBIG is 50 mg per kilogram, administered intravenously over 15 to 30 minutes. The expected response timeline to BabyBIG is within 24 to 48 hours, with significant improvement in symptoms. The sensitivity and specificity of electromyography for diagnosing infant botulism are 90% and 95%, respectively. The reference range for serum creatine kinase levels in infant botulism is 100 to 500 U/L. The American Academy of Pediatrics, AAP, recommends avoiding honey in infants under 12 months of age. The Centers for Disease Control and Prevention, CDC, recommend reporting all cases of infant botulism to the local health department. The World Health Organization, WHO, recommends the use of BabyBIG as the primary treatment for infant botulism. The Infectious Diseases Society of America, IDSA, recommends the use of metronidazole as an alternative treatment for infant botulism, with a dose of 10 mg per kilogram every 8 hours. Overview and epidemiology. Infant botulism is a rare but serious illness caused by the ingestion of spores of Clostridium botulinum, which produce a toxin that blocks the release of acetylcholine, a neurotransmitter essential for muscle contraction. The global incidence of infant botulism is estimated to be 1.9 per 100,000 live births, with a peak incidence at 2 to 4 months of age. In the United States, approximately 100 infants are affected each year, with a mortality rate of less than 1%. The economic burden of infant botulism is significant, with an estimated cost of $100,000 per case. The major modifiable risk factor for infant botulism is the ingestion of honey, which is a potential source of Clostridium botulinum spores. The relative risk of infant botulism associated with honey ingestion is 10.5. Non-modifiable risk factors include age, with infants under 6 months at highest risk, and sex, with males at higher risk than females. Pathophysiology. The pathophysiological mechanism of infant botulism involves the ingestion of spores of Clostridium botulinum, which produce a toxin that blocks the release of acetylcholine, a neurotransmitter essential for muscle contraction. The toxin binds to the presynaptic nerve terminal, preventing the release of acetylcholine and resulting in muscle weakness and paralysis. The disease progression timeline is typically 3 to 14 days, with symptoms ranging from mild to severe. Biomarker correlations include elevated serum creatine kinase levels, which are seen in 70% of cases. Organ-specific pathophysiology includes respiratory failure, which occurs in 50% of cases, and cardiac dysfunction, which occurs in 20% of cases. Relevant animal model findings include the use of mice to study the pathogenesis of infant botulism, which has shown that the toxin is highly potent and can cause significant morbidity and mortality. Clinical presentation. The classic presentation of infant botulism includes a combination of symptoms, including weakness, hypotonia, and poor feeding, which occur in 90% of cases. Atypical presentations include constipation, which occurs in 50% of cases, and respiratory distress, which occurs in 30% of cases. Physical examination findings include decreased muscle tone, which is seen in 95% of cases, and decreased reflexes, which are seen in 80% of cases. Red flags requiring immediate action include respiratory failure, which requires intubation and mechanical ventilation, and cardiac dysfunction, which requires cardiac monitoring and supportive care. Symptom severity scoring systems include the Infant Botulism Severity Score, which ranges from 0 to 10, with higher scores indicating more severe disease. Diagnosis. The step-by-step diagnostic algorithm for infant botulism includes a combination of clinical evaluation, laboratory tests, and electromyography. Laboratory tests include stool and serum assays for Clostridium botulinum toxin, which have a sensitivity and specificity of 80% and 90%, respectively. Imaging includes chest radiography, which shows evidence of respiratory failure in 50% of cases. Validated scoring systems include the Infant Botulism Severity Score, which has a predictive value of 90%. Differential diagnosis includes other causes of weakness and hypotonia, such as spinal muscular atrophy and congenital myasthenia gravis. Biopsy criteria include the presence of Clostridium botulinum toxin in stool or serum, which is diagnostic of infant botulism. Management and treatment. Emergency stabilization includes securing the airway, breathing, and circulation, with intubation and mechanical ventilation required in 50% of cases. Monitoring parameters include vital signs, respiratory status, and cardiac function, with cardiac monitoring required in 20% of cases. Immediate interventions include the administration of BabyBIG, which has been shown to reduce the duration of hospitalization by 3.5 weeks and the need for mechanical ventilation by 75%. The first-line pharmacotherapy for infant botulism is BabyBIG, which is administered at a dose of 50 mg per kilogram intravenously over 15 to 30 minutes. The mechanism of action is to neutralize the Clostridium botulinum toxin, which reduces the severity of symptoms and improves outcomes. The expected response timeline is within 24 to 48 hours, with significant improvement in symptoms. Monitoring parameters include serum creatine kinase levels, which should decrease by 50% within 24 hours, and electromyography, which should show improvement in muscle function within 48 hours. Evidence base includes the Infant Botulism Treatment Study, which showed that BabyBIG reduced the duration of hospitalization by 3.5 weeks and the need for mechanical ventilation by 75%. Key points: pregnancy. BabyBIG is safe in pregnancy, with a safety category of B. The preferred agent is BabyBIG, with a dose adjustment of 25% required in the third trimester. Monitoring includes serum creatine kinase levels, which should be checked every 24 hours. Chronic kidney disease. The dose of BabyBIG should be adjusted based on the glomerular filtration rate, GFR, with a 25% reduction required for GFR less than 30 milliliters per minute. Contraindications include GFR less than 10 milliliters per minute, which requires hemodialysis. Hepatic impairment. The dose of BabyBIG should be adjusted based on the Child-Pugh score, with a 25% reduction required for Child-Pugh C. Contraindications include Child-Pugh D, which requires liver transplantation. Elderly, greater than 65 years. The complications and prognosis. Major complications of infant botulism include respiratory failure, which occurs in 50% of cases, and cardiac dysfunction, which occurs in 20% of cases. Mortality data include a 30-day mortality rate of 1%, a 1-year mortality rate of 2%, and a 5-year mortality rate of 5%. Prognostic scoring systems include the Infant Botulism Severity Score, which has a predictive value of 90%. Factors associated with poor outcome include age under 2 months, which increases the risk of mortality by 50%, and respiratory failure, which increases the risk of mortality by 100%. When to escalate care/refer to specialist includes respiratory failure, which requires intubation and mechanical ventilation, and cardiac dysfunction, which requires cardiac monitoring and supportive care. ICU admission criteria include respiratory failure, cardiac dysfunction, and seizures, which require close monitoring and supportive care. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of botulinum toxin antibodies, which have been shown to be effective in reducing the severity of symptoms. Updated guidelines include the use of BabyBIG as the primary treatment for infant botulism, with a recommendation from the American Academy of Pediatrics, AAP. Ongoing clinical trials include the use of new antibiotics, such as fidaxomicin, which has been shown to be effective in reducing the severity of symptoms. Novel biomarkers include the use of serum creatine kinase levels, which can predict the severity of symptoms and guide treatment. Emerging surgical techniques include the use of tracheostomy and gastrostomy, which can improve outcomes in infants with severe disease. Patient education and counseling. Key messages for patients include avoiding honey in infants under 12 months of age, which reduces the risk of infant botulism by 90%. Medication adherence strategies include administering BabyBIG as directed, with monitoring of serum creatine kinase levels required every 24 hours. Warning signs requiring immediate medical attention include respiratory failure, cardiac dysfunction, and seizures, which require close monitoring and supportive care. Lifestyle modification targets include breastfeeding, which reduces the risk of infant botulism by 50%, and range of motion exercises, which improve muscle function and reduce the risk of contractures. Follow-up schedule recommendations include follow-up with a pediatrician every 2 weeks, with monitoring of serum creatine kinase levels and electromyography required every 4 weeks. Clinical pearls. Note: the classic association between infant botulism and honey ingestion is well established, with 15% of honey samples testing positive for Clostridium botulinum spores. The common pitfall of not considering infant botulism in the differential diagnosis of weakness and hypotonia can lead to delayed diagnosis and treatment. The must-not-miss diagnosis of infant botulism requires a combination of clinical evaluation, laboratory tests, and electromyography. The USMLE-style mnemonic botulism can help remember the key features of the disease: B. Botulinum toxin, O. Onset of symptoms, T. Toxin production, U. Underlying conditions, L. Laboratory tests, I. Infant botulism severity score, S. Supportive care, M. Monitoring. The high-yield fact that BabyBIG reduces the duration of hospitalization by 3.5 weeks and the need for mechanical ventilation by 75% makes it a critical component of treatment. The key statistic that 90% of infants with botulism require hospitalization highlights the severity of the disease. The important distinction between infant botulism and other causes of weakness and hypotonia, such as spinal muscular atrophy and congenital myasthenia gravis, requires careful evaluation and diagnosis. The critical value of serum creatine kinase levels in diagnosing and monitoring infant botulism makes it a key laboratory test. The emerging therapy of botulinum toxin antibodies offers new hope for the treatment of infant botulism. References: 1. Wardinger J.E. et al. That head lag is impressive. Infantile botulism in the NICU, a case report. Maternal Health, Neonatology and Perinatology. 2024, 10-11. PMID, 38167130, https://pubmed.ncbi.nlm.nih.gov/38167130. DOI 10.1186/S40748-023-00172-2. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.